I need to know how to navigate.
Do it by yourself. Are you speaking, sir? We can't hear you.
I just remember now. Good evening, everyone. Today we'll be looking at screening, analysis, screening, and diagnosis tests. And you might have been hearing the word sensitivity and specificity. Now, these two words are part of what we regard as validity. And yesterday we talked about criterion validity. So these specificity and sensitivity, they are part of what we call criterion validity, especially when you have a cutoff. You know, normally when you have a screening test, you must have a cutoff where you say somebody has an attribute. For example, now, you say somebody is diabetic. Before you can say somebody is diabetic, the blood sugar will have been at least 126. So how do they set that? How did they set that value? That's part of what we are going to look at. How do you know the best cutoff? The same thing is somebody that has hemoglobin concentration that is less than, maybe in our environment, 10 grams per day. The cell is anemic. So how do we come about it? So let's quickly look at diagnostic tests. Many diagnostic tests and screening test results are given in form of continuous variable, such as blood glucose, fasting blood glucose, hemoglobin level, systolic or diastolic blood pressure. A positive diagnostic test of systolic hypertension, a positive diagnostic result of systolic hypertension is a systolic blood pressure greater than 140 millimeter of mercury, greater than or equal to 140 millimeter of mercury, whereas a positive diagnostic result of anemia is less than 11 grams per day. Now, how to best choose the cutoff is the subject of this session. Otherwise known as a reference interval, we also want to talk about reference interval. The first thing we'll talk about reference interval. This is otherwise known as reference range or normal range. A concept introduced by Grasbeck and Saris in 1969. This was in response to growing awareness expressed with great clarity in a reflective paper from Schneider that the concept of normal range as then conceived was flawed. Current practice at the time was to compare patient results with an ill-defined or at least inconsistently defined range of value called the normal range. They just define some range of value called normal range. Normal range was derived from an ill-defined population of supposedly normal, meaning healthy individual. So, how do they determine the reference interval? The National Committee for Clinical Laboratory Standards, now called Clinical and Laboratory Standard Institute, has defined a scheme for the determination of reference interval which is as follows. Look at the screen. Reference interval individual comprise a reference population from which a selected reference sample group on which are determined reference value on which is observed a reference distribution from which are calculated reference limit that made. If I see it's very of which, but just look at this flow, or you call it flow chart now. Reference individual comprise a reference population from which is selected a reference sample group of which are determined reference value of which is observed a reference distribution on which a calculated reference unit that define a reference interval. Now, this one should not be tricky to you, because if you remember, when we talk about probability distribution, we talk about, we say it's a theoretical distribution. And there are some things that are attribute. You know, the one that come to your mind, apart from bilateral, symmetrical, bell shape, mean, mode, and median and the same. There's something we say that in between -1 and +1 standard deviation, that's if when you convert normal distribution into standard normal distribution. Between -1 and +1 standard deviation, the 68 point something, 46% lie. We just look 26, I think. So approximately 68%. So in between -1 and +1 standard deviation, 68% of the observation lie. In between -2 and +2 standard deviation, 95.45. But in between -1.96 and +1.96 standard deviation, 95%. We know that. So when they are now talking of reference individual now, if you go to the population and scientifically select through random sampling, you select a sample and take sample, maybe blood sugar, and now look at the distribution of the value. So what you see is, when you look at the distribution, how many, at what value, which value correspond with -1.96 and +1.96 standard deviation. If the attribute we are looking at is when it is excess that the disease is there, like blood sugar, so you will be interested in the value that is above 1.96 standard deviation. But by the time you put value, so you believe that the normal value, normal reference rate should be a value that corresponds with -1.96 standard deviation, and the value that corresponds with +1.96 standard deviation. So anybody that has that attribute that is above that 1.96 standard, we know that is abnormal disease. That's the way to do it. But if you are dealing with attribute that the less the value, the more the disease, like anemia, it is when the PCV or hemoglobin concentration is very low, I say somebody is anemia. So you are now talking about lower limit, anything less than 1.96. So that's how you go to see it. The reference rate. So this International Federation of this thing, what do you call it? Or clinical, whatever. I think I put something there. IFCC, or it's not there. So there's a reference, there's a value. They define the term like a reference value. Okay, International Federation of Clinical Chemistry and Laboratory Medicine. A reference individual is an individual selected for comparison using defined criteria. A reference population consists of all possible reference individuals. It usually has an unknown number and is therefore a hypothetical entity. A reference sample group is an adequate number of reference individuals taken to represent the reference population. Ideally, they should be randomly drawn from the reference population. Can you see now? The reference value is the value test result obtained by observation or measurement of a particular quantity on an individual belonging to a reference sample group, while a reference distribution is the statistical distribution of reference value hypothesis regarding reference distribution obtained from a reference population can be tested using the reference distribution of the sample group and adequate statistical method. The parameter of the hypothetical distribution of the reference population may be estimated using the reference distribution of the reference sample group and adequate statistical work. This is how I just got my body. That's what I just explained to you. By random, you select people in the population. Those are the reference individuals. When you select many people, you become reference sample. You carry out your test on them. You look at the distribution. You look at the middle 95% confidence interval. So a reference limit now is derived from the reference distribution and is used to describe. It's used for descriptive purposes. It is common practice to define a reference limit so that a stated fraction of the reference value is less than or equal to or more than or equal to the respective upper or lower limit. A reference limit is descriptive only of reference value and should not be confused with time decision limit. But the decision limit will be determined by the physician based on experience. A reference interval is the interval between and including two reference limits. The time reference range was rejected because, strictly statistically speaking, range is the difference between the highest and lower value in a number set. It's a single value. So when you're talking about range, or if you say, oh, age distribution, the highest age is 56, the lowest age is 26. The range is 56 minus 26, that's what they're saying. So what is the range? Most of the time, you will not say from this, they just say highest minus lowest. That's why they kick against it. A reference interval. Okay, I think I'll talk about that. Yes. Observed value. Patient test result is the value of a particular type of quantity obtained by either observation or measurement and produced to make a medical decision. It can be compared with reference value, reference distribution, reference limit, reference interval. Now, how do we estimate the reference interval? Method, the normal distribution, and we can use non-parametric percentile, more parametric percentile method. So, International Federation of Clinical Chemistry recommended method for estimating reference interval is the non-parametric method that essentially involves simply excluding the lowest and highest 2.5% of reference value. So, can you see now? 2.5, 2.5. Now, when you have 2.5 to 2.5, it gives you 5. You remove it from the 90, from the 100 is 90. So, any value outside the middle 95%, 95 rather, you remove 5 from 100 is 95. Now, there are options, but of course, you know, one can select 90%, 95%, 99, 99.9, but most of the time, you know, 95 we use. Two-sided or one-sided. You know, there are some attributes, either too low or too high is not good. There are some things you don't talk about, maybe too low may not be an issue, it's too high. There are some things, too high may not be an issue, it's too low. So, when you are dealing with two sides, two-sided, where if it is only one side, one-sided, I think we talk about one tail or two tail. When we're talking, it's the same thing when we're discussing the other time. Double-sided, when there is both lower and upper limit of normal, both low and high value are suspicious. That is, It can be too low, it can be too. That's why sometimes you do a particular test, it's becoming too low, it's lower than the reference, the lowest value. So if it's low or maybe higher than the highest, it's too high also. So, but if it is one-sided, this one-sided can be, now you will not just say one-sided. Is it left-sided or right-sided? Because if something is left-sided, you know what it means. Maybe we are talking of the lower value is suspicious. If somebody is right-sided, that's why you have to separate. So left-sided, when there is only a lower limit of normal and no upper limit of normal, only low value are suspicious. Or something like that. Right-sided, when there is only an upper limit of normal and no lower limit of normality, only high value are suspicious. Can you see? If you look at the diagram now, the one that is both sided, the 95%, the area under the graph is 100%, which is 1. So this yellow area is the middle 95%. So it left 2.5 here, 2.5% here. No, 2.5 plus 2.5 make 50%, 5% rather. So this one that is lower limit, lower sided, you see the 95, the lower you are considering the lower 95 and lower 5%. The 95% is the one above on the right side. Why the other way in this one when it is right side? So if you look at this now, you see I'm coming. So how do you estimate reference interval? Look at it. I've already said analyze concentration. This is the other example. So when you calculate the mean and standard deviation and then calculate this 91.96 standard deviation. So in between minus 1.96 to plus 1.96 standard deviation, 95% of the people have the value. So the area, the remaining 2.5, 2.5, they are the one that have normal. So in between the range now will be the value that corresponds with minus 1.96 standard deviation and the value that corresponds with the 1 plus 1.96 standard deviation. I give you an example that I will, unless those people that were not here, to explain this score. This when I use weight to explain. In that explanation, the mean weight was 70, the standard deviation was 10. Any value that is 50 and 80 is one standard, is just remove 70 from 80, 10. And 10, the standard deviation is 1, is 10. So when you divide that 10 by 10, it give you 1. That shows that 80, if the mean is 70 and the standard deviation is 10, that 80 is one standard deviation above the mean, which is plus 1. 90 will be 2 standard deviation above the mean, which is 2, plus 2. That is 90, you remove 70 from 90, give you 20. 20 divided by 10, it give you 2. The same thing, anyone that weighs 60 is one standard deviation below the mean, which is minus 1. And when you remove 70 from 60, it give you minus 10. Minus 10 over 10, give you minus 1. The same thing, 50 is minus 2 standard deviation below the mean. If you remove 70 from 50, it give you minus 20. Minus 20 divided by 10, it give you minus. So I've explained it. So the number of standard z-score, that's how to calculate z-score. The number of standard deviation away from the mean. We now know that between 1.96 standard deviation and plus minus 1.96 standard deviation and plus 1.96 standard deviation, 95% of the observation lie in between. The remaining 5% are lied either above or below. Now, estimating reference interval using non-parametric method. All the same. If you look at the reference value, you see 2.54 below this, 1.5 and 2.54 above this. So it's virtually the same way. It's the same. They are still using the same 95%. But of course, why they have to differentiate is that there are some, it's not everything that follow normal distribution. The parametric method is the one you assume that follow normal distribution. In the non-parametric is skewed. Now, let's look at example. As part of the effort to determine reference interval, the value of total serum protein in the blood, PCV are alpha alkaline phosphatase were determined for ALPs, alkaline phosphate. You don't bother yourself, you just know that it's one. Were determined for 119 neonate. Neonate means the child between the first 8 days, let's say below 1 month. The table below show the reference interval as determined by both the normal distribution, Gaussian, and non-parametric percentage. You see what they get. Total serum being the mean. Look at the PCV. Look at the alpha alkaline phosphatase. Look at the value for Gaussian method, upper and lower. For serum bilirubin, protein 1.5 lower. No, standard deviation. 4.6 lower, 7.7 or 7.66 upper. For PCV, 35.9 lower, 57.5 upper. Alkaline phosphate, 50.1 lower, 90.9 upper. But if you use the reference, the non-parametric percentile, you have 5, 8. If you look at it, they are very close. What's 4.6 and 5? Can you see? The lower limit for the total serum protein for Gaussian is 4.6. For reference, for non-parametric is 5. For the upper is 7.6, almost 8. The other one is 8. Look at the PCV, the one that differs more. 35.9, which is like 36. Then the other one is 38. Then 58, 57.5, which is approximately 58. The other one is 59. And we have a 15.1 year, 24 year. This was wide range. 19.1 year, 90.9 and 98. You know, the reason is very simple. Sometimes some of these things, normally they are supposed to be normally distributed because the population, you may have some outlier. You know, that's why the International Federation of Clinical Chemistry prefer the non-parametric. Because the parametric, you have to calculate the mean, standard deviation, for you to calculate to be able to know how many standard deviation away. But for this one, you don't need to calculate just the distribution, the percentile. The percentile, if they arrange it from smallest to the lowest, the cutoff, the number that is in position 2.5 percentile is what they're talking about. The other one, 97.5 percentile. Can you see? So now, let's now talk about the criteria. I just give that one so that you have a background on how you determine what is the cutoff of normal or not. But now, there's something when you want to validate now. Imagine there's a method they use to, that's a gold standard. They use to know, what is the level, at what level you say somebody is diabetic or somebody has anemia. I now want to bring another method, another method to do it. So in that situation, this new method, you want to validate it. The other one will be the gold standard. But in real clinical sense, what they do is that they will have some people, general population, they have people, some people are diabetic, some people are not diabetic. Or they already look at the clinical sign. You can see all the features of diabetes. We have the clinical feature of diabetes in this one, and which is, you can easily say, even without test, this one is more likely to be diabetic. And you have some, you don't have that clinical feature, both the sign and the symptom. And you take their blood. Of course, from the signs and symptoms, you already say, okay, this one likely to have diabetes. This one, they don't have diabetes. You now take their blood. When you take their blood now, you enter it. How do we know the cutoff, the real cutoff point? At what blood sugar will you say somebody is diabetic? So in that situation, I want to do criterion validity for the diagnosis of diabetes through blood sugar. Now, the gold standard now will be the clinical symptom that you okay, that will help you to separate the diabetes from non-diabetic. So in this laboratory now, we want to, where is the right cutoff point? Let's look at the weight. So for every diagnosis procedure, there's a set of fundamental questions that should be asked. One, if the disease is present, what is the probability that the test result will be positive? That's what we call the sensitivity. If this person somebody has the diabetes, if I do the test, what is the probability that the result will say you have diabetes? Because somebody may have diabetes and the test result will say negative. So he will not pick it. But the person has diabetes, that is, if you have 100 people that have diabetes, you test for the sugar, and how many of them will you test it, confirm that you have diabetes? That is the sensitivity of the test. So it's not everybody that has an attribute that you test it has, but the higher it is, the more sensitive that result is. That test it. Now, if this disease is absent, what is the probability that the test result will be negative? That is specificity. Somebody that does not have diabetes, you do fasting blood sugar. It's not, there are some people that don't have diabetes, you do fasting blood sugar, it's high. They say, this one is high. Some will say it's normal, it's not high. Some, but the person does not have diabetes, all this everything does not have. They say the blood sugar is so the probability of the testing negative, if somebody does not have the attribute, is the specificity. Specify that yes, these people doesn't have it, and it's very specific that it doesn't have it. Now, that's the second one. The third one, if the test result is positive, what is the probability that the person has the disease? You know, the first two, look at it with the way we start. The first two, we say if the disease is present, if the disease is absent. The first one, if the disease is present. The second one, if the disease is absent. But this last two, if the test result is positive, the next one will be if the test result is negative. Can you see that? So here now in the first one, we are starting with, okay, this person has the disease. If I do the test, what is the probability that you say he has the disease? Or if this person doesn't have the disease, if I do the test, what is the probability that he doesn't have the test will say he doesn't have the disease? That is sensitivity and specificity. But here now, you say people came with results, the results of tests. What is the probability that this person that has this result that is positive, that is actually had the disease? Or that is positive predictive value of the test. Or if the test result is negative, what is the probability that this person that comes with test result negative does not actually have the disease? That's negative predictive value. So maybe before I talk further about that something, okay, maybe when, okay, and then when I get to the table, I will speak more about that sensitivity and specificity and applicability. Now, through diagnosis. This is done through a gold standard. That is what you got. Actually, the person that has the problem. Before you want to validate a test against what? If you want to do this test, you're actually mentioning what is supposed to measure. That is the validity. So which one will tell you that person have the attribute. Which one actually measure the one you want to use? It must be a good standard that measure it before you can say you want to compare that one with the gold standard. For example, biopsy in pathology, that is when it comes to anything that has to do with disease tissue in the body, maybe all the plasma, all those stuff. Biopsy is the gold standard because when they take that lesion, they remove it and put in the laboratory and see is cancer there or not. What is there? That's biopsy. Then there are some other risky procedure that will serve as gold standard. And those biopsy and gold standard is not something you do all the time. Number one, they are expensive and they can be very risky also. You know, for someone that is dead now, you can easily cut tissue and go and pathology, go and study. But somebody that is still alive, to remove tissue, go and test, you remove the tissue for somebody that is still alive. It may not be easy, especially depending on where that tissue, what that problem is. Now, I want you to look at distribution of test results. Normally, when I say test results here now, don't look at this graph. You know, the y-axis is usually the frequency. Remember, probability. Why the frequency means how many of these people have this value. Horizontal axis, as you move to the right like this from the origin, that is the value. If we are talking of test results, maybe 50, 60, 70, 80, 90, 100, all those stuff. As it's increasing horizontally, the number of the sample you take, how many of them in that category, that's the vertical. So you see the people that have without the disease, they are normally, though everybody is normally distributed with both disease and not the best. If you want to, in the context of some people in the population, they don't have the disease. Some people have the disease. So those people that are in the population that don't have the disease, they follow normal distribution. The value you are measuring follow normal distribution. That's the bigger one you see. Believing that a disease majority will not have the disease now. If majority have the disease in population, that shows that disease almost everybody has the disease. Most of the time, it's only few people that have the disease compared with the whole population. So the distribution of people that don't have that disease is bigger. Why? The people that have the disease also follow normal distribution. That's the second one like this. But you can see something that is an overlap. It's not as if maybe it's separate that, okay, where this one starts. No, but this example is drawn for a parameter, a variable you are measuring that the value is higher, you are more likely to have the disease. So, for example, diabetes. But the more the value is, the higher the value, the more likely somebody is diabetic. Hypertension, the higher the blood pressure, the more likely the person is having hypertension. You know, there are many things like that. And but it's not like anemia. It is the less the blood level, the more likely. In that situation, if that's what we plot, the bigger value, the bigger for the lower value will be those who have the disease. That smaller distribution will come first before the other one. So this graph we are seeing is assuming that that particular attribute we are looking at, as it increases, the more likely the person will have the disease. That's why you have a graph of the disease at the right, the number at the left. So you think maybe where the distribution of the people that don't have the disease ends, it is after that that the distribution of the people that have the disease. The overlap, you see that it's overlap. That shows that if care is not taken, when you say you are looking at distribution of people that don't have the disease, towards the right side, you may see some of them, you might have captured some people that have the disease in the population, but the test is telling you that they don't have the disease. Or the people that have the disease, if you look at their distribution, the earlier part, if care is not taken, you can capture some people that don't have the disease as having the disease. So you can see now. So if you see something like true negative means this person, they don't have the disease, and the test day is negative, they don't have. It's true. You see, true positive means these people, they have the disease. The test they have the disease, true positive. The test say they positive for the disease. But down where you have false negative FN and false positive. False negative is the person that the test say they don't have the disease, but in the research, they have the disease. False positive are the people the test say they have the disease, in research, the test say they don't have the disease. False positive. So the problem we are having now, we wish is going to inform what we're going to do now, is at what cutoff then? So alone, what cutoff? So that dash line, if you look at the red line is the lower value of the person that has the disease. The green line is the upper value of the people that don't have the disease. Can you see? But can you see now? So the graph overlap. But we cannot say the cutoff will be at red. If the cutoff will be at red, a lot of people don't have the disease, say they have the disease. If the cutoff is the green, a lot of people they have the disease, say they don't have. So the cutoff has to be somewhere. That dark one, you have to be put somewhere. So it's not arbitrary. And that's the essence of the analysis you want to look at. How do you know the right cutoff? Let's continue. Now, implication of a particular cutoff value. What would be the advantage of selecting the red line as the cutoff value for the normal? If you select red line now, no red line, look at it. What will be the advantage? Number one, all patients with the disease will have a positive test result, right? All the patients that have disease, yes, all of them will have positive test result that they have it. Yes, advantage. What will be the advantage of selecting green line as the cutoff? All patients will, all LD people will have a negative result. All the people that say, oh, they don't have the disease, or LD, they have a negative result if they don't have it. But what will be the disadvantage of selecting red line as the cutoff? Patients who do not have the disease will be classified as having abnormality. Look at it. A lot of people that don't have the under the distribution of without the disease do not say they have disease. So what would be disadvantage of selecting green line? Person with disease may not be diagnosed. So if you say this is cutoff, a lot of people they don't have the disease. They have the disease on the left side. You say they don't have. And you see, it's a dilemma. Now, let's move forward. Which is sensitivity, specificity, and predictive value of the test. Is from when we analyze this, you get to know how we determine the cutoff, the best cutoff that we share the risk on both sides. So when you are, I've already told you, there must be a gold standard, and that gold standard will tell you this person have the disease or not. You believe that is the gold standard. So that is the vertical disease. This disease absent, present, absent. Okay. So how do you know that disease is present or absent? You have used the gold standard. Then the test you are trying to validate, positive or negative. Now, when you bring the two together, so the test is along the horizontal, the gold standard is along the vertical. You remember this A, B, C, D for 2x2 table by epidemiologists is just the standard. A, B, C, D. All these other ones is total. A plus B, C plus D, that's horizontal total. Vertical total, A plus C, B plus D. Now, well, I think I prefer, anyway, let's just first of all say it. There's a real data to explain it. So sensitivity will now say, okay, what is the total that have the disease? The people that have the disease, A plus C, if you look at the vertical, present, A plus C. So sensitivity will be how many of these people that have the disease that test positive? That will be A over A plus C. That's the sensitivity, and you are not express as percentage. Specificity will be the people that don't have the disease, that what proportion the test say they don't have. So the total that don't have the disease, that B plus D. And the one that's negative there is D. So specificity is D over B plus D. Now, when we now talk about predictive value, what is the total that test positive? A plus B. How many of them actually have the disease? Is A. So a positive predictive value will be A over A plus B. And the last one is not the last one per se. How many of them that don't have the disease, that test negative rather, C plus D? How many that don't even have the disease is D? So negative predictive value is D over C plus D. Prevalence of the disease, that is, among the total you study is A plus B plus C plus D. That's the total. The prevalence will be how many of them have the disease? A plus C. So A plus C divided by A plus B plus C plus D. That's the prevalence. So they also calculate the accuracy extent of correct classification. That is A plus D over A plus B plus C plus D. If you look, the correct classification is the concordant. You know, I told you when we were discussing, I made mention of this concordant many times, especially when we're talking about McNema. You see, concordant, look at it. A and D are the concordant because A, the disease is present and the result is positive. D, the disease is absent, the result is negative. These are the concordant. That's correct classification. The other one that are in red, they are discordant. They are false. That's why they call it. If you look at the concordant, it's a true positive, true negative. But the discordant are the red, false positive, false negative. So false positive means that this fellow don't have the disease. If you look at it, the disease is absent, but the test positive. So that positive is false. So it doesn't have the disease, but it tested positive. False negative. This fellow has the disease, but the test is says negative. That not having the disease from that test is false. Does it make sense now? So the correct classification are A, which is true positive, and D, which is true negative. So the accuracy, the essence of correct classification is A plus D over everything. Now, so this one just points division cutoff. I just trying to reiterate what, how do we know the right cutoff? Because you are going to have, you have from this table now, you can classify under, you can put in diagram. You have true positive, true negative, false positive, false negative. So in order to reduce, to reduce false positive and also reduce false negative, you know that if you reduce false positive, you are going to increase false negative. If you reduce false negative, you are going to increase false positive. At what, based on your cutoff. So at what cutoff we try to maximize so that you don't have too much false negative, you don't have too much false positive. At what cutoff? Let's move further. So this example now is just a live example of what we just put there now. Okay. So look at this test. We have three different tests. It's explaining some things for you. Test 1, test 2, test 3. Look at, for the same thing, the first one, 200 people. I think, let's continue. Prevalent. So it's actually, yeah, less. So the first one, there are 200 people. 100 have the disease, 100 do not have the disease. 70 positive, 130 negative. If you had 100 plus 100, give you 200. 70 from 130, whichever will give you 200. So true positive is 68. Or let me, I should be asking you is the question, what is true positive? In that first table, unmute and talk. What is
Positive is 68.
68.
good? Of true negative?
98.
Nice, 98. What of false positive?
False positive.
2.
2, yes. Then false negative, that's 2. Now, sensitivity. Okay, that's the prevalence of the disease. Scenario A. Prevalence of disease is 100 over 200. I mean, well, I should be asking you, on a calculator anyway, 100 over 200 is the prevalence, which is 50%. Sensitivity is what? Be telling me.
True positives over
Yes,
total.
just give the figure. Give the figure is there. Just give the figure. Something over something.
60 over 100.
Is it 60? Sensitivity is 68.
68, sorry.
68 over 100, which is 68%. What does specificity?
Answer is then.
Now, see it down.
98 over 100.
98. You see, when you are reading it, you show you are following. As I'm talking, some people are cooking. That's why you have they are not answering. 98 over 100. 98%. So the positive predictive value is what?
68 over 70. 68 over 70.
Yes, 60 over 70, making 97.1%. Then negative predictive value is what?
98 over 130.
Which is 75.4.
Yes.
Before we talk about the next scenario, some explanation I want to give about this sensitivity and specificity and negative predictive value and positive predictive value I want to give now. Now, what is the essence of this sensitivity and specificity? Is the clinicians, the doctor, that's interested in that. Because when the people that are doing the test, there's a head worker generally. That's their interest. This test I want to use to know if these people have this disease. How good is this test? If I'm presented with 100 people that have the disease, how many of them would this test tell me they have the disease so that I make the right diagnosis? That's sensitivity. If I'm presented with 100 people that don't have the disease, just like that scenario 1, how many would this test tell me they don't have the disease? That's specific. Is the headache of health workers. That's what they're interested in. This negative predictive value and positive predictive value is the headache of the client, the patient. But of course, it's the headache of the patient. They will not bring it for the doctor, health worker to solve the riddles for them. So, mind you, the health worker is interested in that sensitivity and specificity of the test, because you make him to make the right diagnosis as far and make the right judgment as far as is concerned. But it's the client that plays with positive predictive value and negative predictive, even though they don't know. It's you that call it positive value and negative, but they don't know. Imagine you give somebody test now, they say HIV positive. I'm sure any health worker will have experienced it if you practice for at least 3 years as health worker. You will have experienced it where a relative, someone that is good, may not be related, they don't refer to you. Say, this person did this test. It's waiting for you. Even if you say you are not available, they wait. You really know how important that is to them. They say, I did this test. You see, it's positive. The question you ask you is a doctor. From your experience, does it mean I have HIV? Can you see? Some of them intelligent people now ask you, you see how you from your experience now, how to for anybody that have this test result like the positive, what proportion of them usually have the disease? Can you see? That is positive predictive value. They want to deny, does it mean I don't have the, so I have the disease? So from here now, whenever, so out of 100 people that have the disease, how many actually turn out to have the disease? That is positive predictive value of that test. Because for the fact that test is positive does not mean that that person, the disease is there. So it's the positive predictive value we have to know, whenever this test is positive, positive predictive value is very high. The same thing, someone that they say they are screening for cancer or HIV, and that kid, negative result, he will be happy. But he want confirmation from you. Does that mean I don't have HIV? I don't have the cancer? They will ask you, from experience, when this result turn negative like that, what proportion do you usually have this? It's actually true that we don't have it. Can you see now? So it is still left for you, you as a worker, your own interest is sensitivity and specificity. But the interest of your client, you don't know what concern them about sensitivity and sensitivity. It's for you to make your diagnosis, but what concern them when they get their result? Is it, do I have it? Don't. If they get a positive result, doesn't mean that I don't have it. If they get negative result, and if they get positive result, doesn't mean that I have it. If they give negative result, doesn't mean that I don't have it. They are asking you. Can you see now? Now, let's move further. Let's look at, because there's another point I will let you know by the time we go to the second one. The second scenario, what is the true negative air and true positive air? Please, if you prove that you are following, to prove that you are following. True positive, please. Unmute, if you are talking, you have to unmute.
True positive 68.
68. What are true negative?
True negative is 980. The second one now.
980, yes. That is the D.
Yeah, the D.
It's only Dr. Ngozi that is talking. Dr. Richard, are you there? Then what of false positive? Are you following? What of false positive?
20, sir.
20, yeah. Then false negative is 32. Now, prevalence is what? Prevalence is what? Somebody talk now.
0.09%.
That's 100 over 1,100, which is 0.09, yes. Which is 9%. 9 is the percentage I put in the bracket. When you solve the decimal, that's 0.0 something. When you multiply by 100%, it's 9%. Yeah, what of sensitivity? How many? Somebody should answer.
68%.
What of specificity?
98%.
98%. What of positive predictive value?
77.3%.
Thank you. Then negative predictive value.
96.8.
Okay, thank you. Now, If it tells you somebody's already say okay. Let's now go to the third one before I make my point. So what is the proof positive here?
68, sir.
Yeah. What of true negative?
9,800.
Yes, thank you.
Then
What
Baba
of
you
true
get a sheep.
false positive?
200.
200, yes. Then false negative is 32. So prevalence is what?
1%, sir.
What of sensitivity?
68%.
68%. Then what of specificity?
98%, sir.
And positive predictive value?
25.4%.
Negative predictive value?
99.7%.
Thank you. So what you discover that one, as you are going from the first to second to third scenario, the prevalence of the disease is going down. So the disease in different scenarios, the disease is rarer in the third, rarer in the second. Then is where we cannot say, we know that the second is rarer than the first. The third is rarer because the prevalence is becoming low and low. But look at the sensitivity. What do you see about all their sensitivity? How do you notice?
They're all 68%.
They are the same. And their specificity also the same. But you see that is the predictive value that is changing without change in the prevalence. Can you notice? It's the same disease, different scenario.
Yes, sir.
So the predictive value. So what really happens that they carry out the same test in different populations that have different prevalence of this disease. So sensitivity and specificity, it doesn't have respect for prevalence. It's the same. It's constant. Whether the disease is high in the high body area or low body area, that test, the sensitivity and specificity remain the same. But the prevalence of diseases affect the predictive value. So there's one statement that is very, very crucial. When the disease prevalence is low, when the prevalence of a disease is low, a highly sensitive test will have low predictive value. Imagine sensitivity of 68. When the first scenario, the positive predictive value is 97.1. When the disease become rarer, become 9% prevalent, the predictive value change to 77.3, and the sensitivity is still the same. When the disease prevalence become 1%, the predictive value, positive predictive value, go to change to reduce to 24.4, 25.4. For example, HIV, you know, they usually do seroprevalence every year. No, in all the states. The state that have been having the lowest prevalence is Osun State all the time. Have been having the lowest prevalence when they ran the state about the prevalence of HIV. But the state that actually have the highest actually vary. Sometimes they will say Cross River, sometimes they will say Benue, they say in rivers, they talk about many states. But the issue is that the prevalence varies across state. But the test, the same test you are using, the sensitivity and specificity remain the same. Doesn't really matter. If you go and do in Osun, it gives you the same sensitivity and specificity. Do it where is the highest, it gives you the same thing. However, where the prevalence is very low, even a highly sensitive test will give you low predictive value. While where the prevalence is very high, when the prevalence, yes, when the prevalence is very high, the sensitivity, the predictive value will be high. What it's telling you is that if you do the HIV, they say you are in Osun, you give you positive result. They say you are positive for HIV in Osun. The probability that you are positive is very slim because the prevalence of disease is low there. The probability that that result is actually positive is very slim. It may be less than 20 or 10%. But if the person is in a high body area, if they say the person has HIV, the possibility that actually when the test say, you are HIV positive, the possibility that the person is positive is a little bit high. When we say high is relative, because may say 30 is high, because the HIV is not a desirable something. So the issue there is that when the prevalence of a disease is low, even a highly sensitive test will give low predictive value. So you may be saying, some of you are not clinician, but you look at public health now. All this screening for HIV, even for cancer. A lot of people have NGO, they choose screening pathway, cervical cancer, breast cancer, method of screening. That method, how good, how valid is that method you are using to screen? That's how to know. To calculate the sensitivity, specificity, positive predictive value, and negative predictive value. In fact, my students, they are just graduated. I gave them the question, compulsory, about this scenario of screening for cervical cancer. Talk about this sensitivity, the test they want to do. How would they know? How would they ensure all those things? I asked the question, the tricky way for them to solve. They have to calculate the sensitivity, specificity, positive predictive value, and negative predictive value. They are not medical people. They are public health, PSC public health. Because they go out, the scenario I give them is not clinical scenario. It's a public health scenario that they will encounter. No. So point to know, I think all those points I will have said them. Sensitivity and specificity yield consistent result for the diagnostic test in a variety of patient group with different disease prevalence. However, positive predictive value and negative predictive value are affected by the disease prevalence. When the prevalence of a disease is low, a highly sensitive test will give low predictive value. I think I've explained that. Now, let's move to the cocoa. If you plot, this graph should not come in. This graph should, let me scale down. I don't know why the graph is there. So how do you determine the cutoff point and even run all those? We know that, look at the same table I brought again with the picture. Sensitivity plus, sensitivity is true positive plus false negative is equal to 1. What you mean by 1 is that if you had all the people that have the disease, the will that give you, if there are 100 of them, if 50 give you true positive, the remaining 50% will give you false negative. So true, that is, look at vertically, they will add up to 100 at 1. We say 1 mean 100. 0.5 mean 50%. 1 mean 100%. 0.8 mean 80%. So 0.3 means 30%. So you should understand. Sensitivity plus false negative rate give you the A plus C, which is the total 100. We give you 1. Or you can say false negative rate is 1 minus sensitivity. The same thing, specificity plus false positive. You know the specificity is true negative now. Plus that false positive. Those are the people that don't have the disease. They add up to. So it's got to 1. So you can say specificity is 1 minus false positive rate, or false positive rate is 1 minus specificity. So they say use mnemonic to record this, that sensitivity plus negative, that's false negative. Specificity plus positive, false positive. So can you see? P, specificity, positive, that is false positive, plus false positive, they may give you 1. Sensitivity and false negative give you 1. Now, how do you, let me see where, no, come here, something here. Now, I want to explain something here. The test for you to know the best cutoff, that's what we call likelihood ratio. I think that's the cutoff point. So you want to actually get to a point where the test will give you highest sensitivity. That is, if somebody have the disease, you say you have it. That's true positive. Then to give you lowest false positive. Can you see now? Lowest false positive. Positive, you test, you want to test that give you, of course, highest true positive and lowest false positive. Now, it's like when you are tuning a radar, because that's what lead to what we call ROCs. Receiver, the plot, because determination of that cutoff is what we use a graph called receivers operating characteristic curve. The people that are working using transmission, working with radar, they are tuning the transmission. They begin to tune until, because as they are transmitting, two things, they are interested in signal. But noise also comes. So they will not tune when they have maximum signal, lowest noise. Maximum signal, minimal noise. That will be the best tune. So from this, let's identify signal, let's identify noise. What is the signal in all these tests now? True positive, false positive, false negative, true negative. Which one is the signal? Logically, I want you to, which one is the signal? What are you looking for, per se? Which one is the signal? On mute, if you are mute, I cannot hear you. On mute and talk. Mercy, are you there?
Yeah, but I don't understand it.
So I'm here. So you said the signal for.
I'll give an example.
Yes, sir.
I said that for you to know the best cutoff point, you want to divide signal over noise. If you remember, for you people that we started together, when we were talking about assumption and hypothesis test, I told you the logic behind hypothesis test is that you are dividing the true difference you are looking for over the noise. The true difference is a systematic difference over the inherent variability. The true variability is you make it the numerator, So your test will be significant when you have highest, the numerator is highest, and the denominator is smallest. It gives you a big result. It's the same thing here. Among the four outcomes now, true positive, false negative, positive, false negative, true negative. One is signal, one is noise. I give an example. When you are tuning your radio, you will get a signal, you are getting noise. But you tune to where you get maximum signal, minimal noise. So that is, if you get maximum signal, you divide by minimal noise. It gives you a big value. So maximum signal, the signal will be the numerator, the noise will be the denominator. And I say, which one is the A between A, B, C, D, or TP, true positive, false positive, false negative, true negative? Which one is signal? Which one is noise? Tell me signal first. You want to tell that you are following me.
Signal will be true positive. Will be the signal.
True positive is signal, yes. True positive, because when you are testing, you want is the positive result for the person that has the disease here. You want positive, true positive. What is this noise?
Negative.
Eh?
False positive.
False positive. Because it's noise. Somebody give you positive result and it's not true. That's noise. Forget about negative. You don't even want to. Negative mean that yes, this person does not have the disease. So it doesn't produce you noise. It's the person that you say you have HIV and you don't have, it's the noise. Somebody that has HIV has it. That's signal. But the false positive, the person that doesn't even have it, they say he has it, is the noise. Are we following now? And we know that the sensitivity is the true positive. We know that specificity is the true negative. But one minus, this false positive is one minus specificity. We have already demonstrated it there. Can you see now? So if sensitivity is the signal and the noise is one minus specificity. So if we now say sensitivity divided by one minus specificity, that was called likelihood ratio. Likelihood ratio of the test is sensitivity divided by one minus specificity. The value what it gives you is that how many times the test will tell you the people that have the disease have it more than it will tell you that the people that don't have the disease have it. And you know how many times the test will tell you that the people that have the disease they have it more than when it will tell you that people that don't have the disease have it. Can you see that? Because the people that have the disease and have it is too positive. The people that don't have the disease, test saying they have it is a false positive. So true positive over false positive is the likelihood ratio. And you know that true positive is sensitivity. False positive is one minus specificity. So sensitivity over one minus specificity is the likelihood ratio. So what we do is that you naturally, if you have to do it with your hand, you have different cutoff point for that something, and with different cutoff point for that something, you calculate sensitivity and specificity, and now divide sensitivity divided by one minus specificity. You want to give you the highest likelihood ratio. That cutoff point is the cutoff. Does it make sense now? So if we look at it now, we're going to run it. Maybe you appreciate it better as we have. And know that this one. This is the graph with the spaces. So I have there's one data there now. Let's look at it. Let me stop sharing. We have a data set for it. But it's not this one we use to illustrate. Somebody to share ROC. ROC. I will explain the data set, then we'll run it. ROCs, please.
RO.
ROC.
Share. Okay.
Yeah, it's coming. Yeah. So you can this obesity mark, you can delete it because I've already may leave it so that we don't leave it, don't worry. I even deleted it from my own now today. So the data set we have now, we want to use mean arm circumference. I don't know if you know this mean upper arm circumference. Upper arm like this, you need to assess the nutrient status of children. So they don't actually use it to assess obesity because they just say mean arm circumference is low, the size is minority. We want to see, okay, can we use it to assess obesity? You want to test. So the value under MAC now are the value you got from the children, all the children. I don't know their sample size, maybe plenty, this folder. All the children. Then you want to know the cutoff point. What is the cutoff point? If you want to use it to the best cutoff point, we'll be able to calculate the sensitivity and specificity also. The best cutoff point for this MAC for obesity. Of course, you must have a gold standard. What this is obesity BMI. So the obesity BMI, we have already coded it. 1, obese. 2, not obese. You can click on that view, you see. Click on the view, you see the coding, you see. Click on the view.
Very review.
Look at the view now. The view under
Okay.
B55, click.
Mm.
Go to value label. Check that value label. Value label, check it. Click on it. Can you see? So, where the hand is, all those two, say no, you don't have obesity. The one that is 1, they have.
Yes.
The same thing, that obesity mark is the one we have already done. To run the sensitivity, I already done it. That's why I say you should even delete it, but let's leave it. But now you have already have, that's the gold standard. It's already there. That these are the people that are obese. The people that are not obese. Actually, it's for adults because if you look at the age, 76. So if you can use mean arm circumference for adult to know if somebody is obese or not, they already know the value for BMI, that this person is obese to BMI. We want to validate. So the BMI is the gold standard. They want to use the mean arm circumference to see if it is so sensitive. Now, analyze. Analyze. You go down, you will see there is under classify. Go to classify. Classify. Go up small. You see ROC curve. Second to the last. ROC curve. Click on it. Your test variable is mark, mean arm circumference. Mark. If you look at it, that's the only one that's continuous there is number. It's not category, it's quantitative. Move it now. Then you see state variable. State variable is the one you want to use as your gold standard. Obesity BMI. That's what you move there. Yeah, move obesity BMI. You now what is the value of state variable? The way we have coded the people that are obese, 1. You have put 1 there. Now, under the ROC curve, you see with diagonal reference line. You can put it there. Click on with diagonal reference line. And then put coordinate point of the ROC. Coordinate point. Click. Okay, well, wait. Go to options. But you are not going to do that. I just want to show you something. Go to options. You see, by default, you see it has click include cutoff value for positive classification. That is what it means that there are some things you see, the cutoff for diabetes is greater than or equal to 126. Some people they say just greater than. So if you want to exclude the cutoff, you want to say that the cutoff point is greater than or less than. But if you want to include it, you say you want to be able to say greater than or equal to. Can you see now? So that's the common, and that's why they put it as a default, unless you want it otherwise. Go look at the second one. Test direction. Larger test result indicate more positive test. This one now, the more the MAC, mean the more obesity we are looking at, which is by default is like that. For example, now, issue of diabetes, the more the blood sugar, the more likely to be diabetes. But if it is anemia now you are doing, you have to change this thing. Imagine is hemoglobin concentration or PCB. Anemia. No, if PCB is low, that's anemia. In that situation now, you have to say smaller test result indicate more positive test. Does it make sense? But in these two cases, in this assumption, they just assume, okay, larger test result indicate positive. Continue. Just continue. So you need to note this. Continue. Click on continue.
Click on it.
Okay. Okay. Click on okay. Because the detail was not ready. So stop sharing and share the result. Oh, is it as mad as sharing or Mercy? It's Mercy.
Mercy.
Okay. Scroll down. Is it that is that the memory is small? The RAM.
Sharing now, but
Hey, we have not seen it. Scroll down. Maybe you will scroll down. What is graph? It may take some time. It's graph because it's plot graph.
I did not plot graph on my own end. Though.
You cannot plot graph.
No, I did not plot graph. It just said something. Let me share what it's saying.
It's no problem. That's the problem there.
Someone
Okay.
has the graph.
What is
See
here?
the
Your
graph
own has graph, Abi?
now.
Eh? Who has this one?
See the graph now.
Yes, yes. Has now.
It took some time.
That's what I'm saying. It's the memory. Wait. You see the graph now. The graph is plot. It's okay. Show the graph very well. Scroll up so that we can show the whole graph. Let people see the whole graph. Expand this thing now. You see that the sensitivity is plotted as vertical. 1 minus specificity, which is the false positive, is plotted as horizontal. Signal is plotted as vertical. Noise is plotted as horizontal. we see, for you to know that the signal is higher than the noise. As the signal is coming, the noise is coming horizontal small, the signal is jumping up. That is why the diagonal line will include. If let's say that graph, the closer to the diagonal, the less the usefulness of the graph, the less the likelihood ratio. If the graph is along the diagonal, it's gambling. It's like 50-50. It's telling you that if you say, it means that if the diagonal line means that 50% of the time, the test will say the person that has have a disease have the disease. 50% of the time, it will tell you the people that don't have the disease have the disease. So it's like 50-50. The true positive and false positive, 50-50. That is what will give you, if let's say that graph follow that diagonal. In fact, if we go below that, so that it's worse. But now the area under the graph, check down, you give you the area, go down small. Can you see? Is 0. The total area in the graph is 100%. The area under this graph now is the total should supposed to be 100, but the area is 0.757. The higher the area, the higher the discriminating capacity of the test. Discriminating capacity means to discriminate between the people that have it and people that don't have the disease. To be able to tell you that, oh, the people that have the disease, they have it. The people that don't have the disease, they don't have it. That is discriminating capacity. The higher the area under the graph, the more. Now, see, show the graph very well. Go back to the graph. Let me show it very well. Scroll down so that we see the graph very well. Mercy.
Sir?
Scroll down. It's like you are not there. You are cooking.
Sir, I'm here.
Scroll up, rather. I want to see the graph very well first.
Okay, I'll see the graph very well. Okay.
And so that I want to explain something.
Okay, see the graph now.
Now, the best cutoff, if you want to get on the graph, can somebody tell the most uppermost and rightmost? Go to the graph. We are coming back to that thing. The most uppermost and rightmost place. Uppermost and rightmost. The most uppermost and rightmost.
1.0.
Eh?
1.0.
0.0.
1. 0. 1.0.
Is that place will be something above that 0.2 of that sensitivity. You examine now. Sometimes it may not be true prominent, but that's the place. Now, go to that table down.
I should go down.
And yes, to this table. We show the coordinates. Let's go to the coordinates.
Okay, coordinate of the curve.
Yeah. So what he does now, he shows different value for the cutoff. Can you see now? He shows different value, all the available value, all the available value of that mean arm circumference. He put all the available and calculate the sensitivity and one monospecificity for it. But you cannot, we want the best cutoff, and the best cutoff is the one that has the highest sensitivity and the lowest one minus specificity. And by looking at it, you cannot know it. What you do, I don't know why they don't actually show it. But it's left for you to show what I actually do. Copy this thing now. Copy that table. Right click on it.
Okay.
Copy it. Right click. Copy, not copy as. Copy. Oh, can you copy it as a Excel worksheet? I don't know that one. Go and open Word document and paste it. Open Word document and paste it. And now share. Open a Word document outside the room. Paste it on it and now share the Word document with us. So I want to tell you how you can bring it out.
I'm opening a Word document now.
And paste that in there. Because you cannot paste directly on Excel.
Okay, I've pasted it now.
So stop sharing this one and share that one. Share the Word document. Why is your own having dark background? So now from the Word document now, you can select even from the title, just select down and copy. You can go and paste on Excel. No, not all those titles. From positive if, from that positive down immediate title. Or you may not even, or you can select only, just for you to know that that second one is sensitivity, the last one minus specificity. So select all the something, the value in all the things and go and paste on it. Select first. You have to highlight all of them now. Select all of them. On to the end. It has ended, eh? Oh, it has not ended. Just right click and copy. Right click on it. You have to right click on it, otherwise you right click on it. We didn't see it. Copy. Have you copy?
Yes, sir.
So open Excel and go and paste it on Excel.
Okay.
Open a new Excel, put it on Excel, and share the Excel. Stop doing this and share the Excel. So this is supposed to be workshop so that it's practical demonstration.
I'll just click here, paste. Okay.
Okay, great. So for you not to be confused, put your cursor on number one, on that one, you go one and insert. Insert so that you insert a row above that. Insert now. So type on the second one column sensitivity, because that is sensitivity. Second, yes. The other one I call sensitivity. Then the other one, the third one minus specificity. Just put figure one minus. Move to the third. You have to move, get out of that. Enter first. You move your hand and then get to that one. One minus sensitivity, specificity. So the last, enter, so that I get out of that place also. The last that the other column, the next column, type on the tail L likelihood ratio, LR likelihood ratio. Just put LR, capital LR, LR, LR. So the first one, the first row under LR, go put your cursor on the first row. Put equal to, press equal to. Click on that, the first row of sensitivity. Click on it. Then divided by slash on your laptop. That's divided by which is slash. Click on the first row of 1 minus specificity. Press enter. If let's say you want to, yeah. Now put your cursor on that one, LR1, the first one you have done now. Put your cursor at the angle, lower right angle, and to give you a plus sign like that. At that corner, put your cursor on that corner. Drag it down. Drag it down to the last row. Yes, it's okay. So can you scroll now? It has calculated the likelihood ratio for you. But what you did, you did for each of those cutoff, you did sensitivity divided by 1 minus specificity. Can you see that, bro? If you count, you got to see some figure. It's the highest value. Scroll down. I can see 60.06. Scroll down. It's scrolling down. I've seen 16. I think it appeared to be the highest. 60 point, yes. 60.0, let's say 60.1. That's the highest. So now, sometimes also, if you, instead of searching, you cannot see, you can go and sort. If you sort it according with this LR, it give you maybe the smaller to the highest, it give you that one first. But leave it. You want to sort. If you want to sort, you have to put your cursor on the D. Put your cursor on D, because D is the column. If you select D, click on D. If you click on D, yes, you go to sort. Sort from largest to smallest. Yes, just says sort. Can you see now? Okay, can you see there's 18? Like 18.1, we didn't even see. Can you see? That's why you go to sort 18.1. So what is the sensitivity, corresponding sensitivity for it? 80.1, the highest value.
Sensitivity is 0.181.
Which is 80.1%. What was specificity? We got to 1%. So can you see now? It show you, number one, that BMI is not sensitive, it's not a good something, because the sensitivity is low. The specificity is low also. So among people that are obese, it can only tell you 80% is obese. Can you imagine? Among people that are not obese, it can only tell you 1% is not obese. Can you see now? Because that's the best customer, and that best customer is the one that discriminates, and that's the best one that is made between the people that have it and you that don't have the obesity, according to that BMI. No, not BMI, according to the mean arm circumference. Any question? It's a little bit tricky, I mean. The more you do it, the more you know it. That's why it's good. Read, do, do. You read about it, you do it. You read about it, you do it. Any question? No question. This is 10 minutes.
No question.
That's the end of the show.
Hey.